Hello, everyone, and welcome to today's webinar, Colostrum Mastery, Bridging the Gap Between Science and Practice. Before we get started, I would like to go over a few items so you know how to participate in today's event. You have joined the presentation listening using your computer's speaker system by default. If you would prefer to join over the telephone, just select phone call in the audio pane, and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. Today's webinar is being recorded, and you will receive a follow-up email with a link to view the recording. I would like to begin to introduce our two speakers. Our first speaker is Dr. Sarah Reyes. Dr. Sarah Reyes is a human milk specialist. Over the past decade, her research has centered on understanding how the composition of human milk shapes infant growth and development. Dr. Reyes received her PhD in human nutrition from Cornell University and completed postdoctoral training under the mentorship of Dr. Megan Azad at the University of Manitoba. Currently, she is a full-time independent research consultant. She helps human milk and nutrition companies design, conduct, publish, and share research about maternal and child nutrition. Our next speaker is Jenny Murray. Jenny Murray, BSN, RN, IBCLC, is the Clinical Education Manager supporting North America. She's responsible for providing clinical expertise on the delivery of neonatal, newborn, and pediatric nutrition, as well as maternal lactation. Jenny presents the science of both clinical audiences and new parents. Within more than 20 years' experience as a neonatal nurse, Jenny has served in a variety of nursing leadership roles within the NICU. These experiences fostered her love for education and research, with a special interest in supporting clinicians to advance the innovative world of neonatology. Jenny holds a Bachelor of Science degree in nursing from Baylor University. She was inducted into the Tenet's Hero Hall of Fame in 2015 and featured in the American Hospital Association publication for her leadership, clinical expertise, and deep connections with family during and after their infant's stay. She received the Excellence in Nursing Award from D Magazine in 2016. I would now like to go ahead and introduce Dr. Sarah Reyes. Doctor?
Thank you so much. Good morning, everybody. Afternoon. Before we do get started, I do want to thank Angela Lang and the team at Medela for organizing the webinar. I really appreciate the invitation to speak. I'd also like to thank Jenny, my co-presenter. Working with you has been a pleasure. Let's see. So up front, we do want to share a few disclosures. First, I am a current member of Medela's Scientific and Clinical Advisory Board. Second, I am the owner of Rev Bioscience, a nutrition research consulting firm. We have active collaborations with Medela, including a white paper about colostrum, which will soon be publicly available, actually right after this webinar. And then, of course, Jenny is a nurse, IBCLC, and is a current employee of Medela. Finally, we'd like to note that in this presentation, we'll use a lot of different terms, which may include breast milk and mother's own milk. We use these terms because they are common in published research, but we do recognize the changing landscape around more inclusive terminology. Research has consistently shown that infants fed human milk, indirectly or directly at the breast, have improved health outcomes compared to those fed formula. Breastfed infants experience fewer episodes of otitis media and diarrhea. They also have lower incidences of respiratory illnesses, asthma, atopic dermatitis, obesity, child leukemia, diabetes, and are less likely to die suddenly from SIDS. In many instances, feeding human milk, even just one time, is associated with improved health outcomes. And as a human milk scientist, I have been fascinated by how. How could human milk have such a profound effect on infant health? And to begin to unravel this question, we can first look at the obvious differences between formula and human milk, the composition. And although commercial infant formula has been able to meet the dietary needs of infants in terms of macro and micronutrients, there are dozens of other components in human milk that are either completely absent in formula or at 8 to 10 times their concentrations. And something else about breast milk is that its composition isn't stagnant like formula. It's dynamic. It changes over the course of a feeding, with foremilk rich in sugars and hindmilk rich in fats. It changes over the course of a day, with milk produced later in the day, for example, has more melatonin than milk produced earlier in the day. Milk composition also changes over the course of lactation. For example, many of the biologically active proteins unique to human milk are at very high concentrations early postpartum. And the highest concentrations are in the very first milk produced, colostrum. Colostrum is unique in its composition as well as its consistency. Colostrum is thick and sticky with uniquely high concentrations of immune factors, bioactive proteins, and nutrients, including vitamin A. The abundance of vitamin A contributes to colostrum's rich golden color, earning it the moniker liquid gold. And because many of these components in human milk are at their peak concentrations in colostrum, it's currently thought that these elevated levels serve as initial loading doses, so to speak, offering additional protection against infection as the infant's immune system transitions from being tolerogenic in utero, which prevents miscarriage, to immunogenic after birth, which helps prevent and fight infections. Colostrum production begins during pregnancy and continues to be produced for the first few days after birth. Over the next few weeks, the composition of milk transitions, becoming what is considered mature milk around 3 weeks after birth or so. Today we have 3 objectives. We'll start with the molecular science of why colostrum matters. We'll learn how colostrum is an important part of the natural, coordinated, and complex process to adapt to extrauterine life. Then we'll get practical. We'll discuss ways to optimize colostrum provision in term infants through skin to skin. We'll focus on the importance of early initiation of breastfeeding to ensure infants are getting as much colostrum as possible. We'll also discuss best practices for increasing skin to skin in your units. Finally, we will discuss ways to implement oral immune therapy for critically ill infants who are NPO or not feeding by mouth. These infants can be given small amounts of colostrum in their mouths to help protect the mucosal barrier and prevent infection. First, let's dive into the science of colostrum and its physiological importance for infants. Birth triggers several physiological changes in the newborn. The lungs, previously immersed in amniotic fluid, now breathe air. The circulatory system undergoes adaptation, functioning independently of the placenta. The infant gains the ability to regulate temperature autonomously. The kidneys start producing urine. And simultaneously, the closure of the umbilical cord marks a significant transition as the digestive system kickstarts, allowing for processing and absorption of nutrients from food. And what's interesting is colostrum really is designed to be a bridge to extrauterine life. Not only is it incredibly nutrient dense, but it also serves as a laxative, aiding in the expulsion of meconium, which helps clear the newborn's intestines of waste products accumulated in utero. Colostrum also serves as immune support, providing maternally derived immune cells to protect against and help fight infection. Colostrum also contains a plethora of bioactive components such as growth factors, microbiota, and human milk oligosaccharides that help the development of the gastrointestinal tract. And the way the way this works is actually quite remarkable. First, the volume of colostrum is very low. Only about 30 to 40 milliliters of colostrum is produced every 24 hours for that first 1 to 2 days. But each drop is thick and it's sticky. And as it's swallowed, the thick, sticky colostrum coats the mucosal surfaces in the mouth, esophagus, and intestines. And when you zoom in, for example, to the intestinal lumen, if you look on the right, you can see these villi structures. The villi increase the surface area of the small intestine to allow for more nutrient absorption. And these villi are actually pretty short in neonates compared to adults. And what the colostrum does is it comes in and covers these villi, creating a surface barrier. And this is important for several reasons, one of which is related to this mucus layer. So if you look on the left-hand side, you can see this mucus layer lays right on top of these epithelial cells. But this mucus layer is actually relatively thin in neonates. The mucus layer itself, though, is really important because not only does it create a surface barrier that prevents microbes from interacting and crossing the epithelial barrier, but it also contains immune and growth factors. So if a pathogenic microbe does manage to reach these epithelial cells, the immune factors can help neutralize or kill the pathogen, and the growth factors can help stimulate the production of new cells to repair the damage. And if you look on the right-hand side, one of the hallmarks of disease is actually the loss of this mucus layer. As you can see on the right, this is an extreme example that occurs, such as during necrotizing enterocolitis. There's this significant loss of the mucus layer. And this makes it easier for pathogens to reach and cross that intestinal epithelium so that they can infect the infant, which of course also increases the infant's risk of sepsis. Now, what's really interesting is one of the roles of colostrum is to provide this initial surface protection for the mucosal surfaces as they mature and are able to provide adequate self-protection through this mucus production. And what's really interesting is, similar to the mucus layer itself, these thick, sticky drops of colostrum contain a variety of maternally derived immune factors such as immunoglobulin A, a variety of antimicrobial proteins and immune cells that help protect this barrier from invading pathogens. And to put this into a little bit more of perspective, here are two of some of the most abundant immune factors in human milk: lactoferrin and secretory immunoglobulin A, or SIGA. And as you can see, the concentrations of these two proteins are several-fold greater in colostrum than in mature milk. And a recent in vitro study also demonstrated that the immunoglobulins, in this case IgA and IgM, these immunoglobulins from colostrum have the strongest reactivities to pathogens compared to raw or pasteurized mature milk. So in this graph, you can see on the y-axis is basically a measure of how reactive these immunoglobulins are against bacterial lipopolysaccharide, or LPS. So LPS is a major component of the outer membrane of gram-negative bacteria, which include many pathogenic bacteria. So basically, in this experiment, the researchers essentially incubated the IgA and IgM with LPS and then detected how strong the reaction was. So as you can see, the raw colostrum indicated in the light gray bars in both images had significantly stronger reaction than the mature milk for both of the immunoglobulins. And what's even interesting is that pasteurization significantly reduced the reactivity of these immunoglobulins, both pasteurized colostrum and pasteurized mature milk. And this really underscores the importance of ensuring that infants are receiving raw colostrum for the highest pathogen protection to maintain that integrity of that surface barrier for the mucosal surfaces. Another primary actor in helping to create the integrity of this surface barrier and prevent against pathogen invasion are HMOs, human milk oligosaccharides. So HMOs are really interesting because they are complex carbohydrates. They form various structures. If you can see on the left, here are some of the examples. And what makes them interesting is that they are highly abundant in human milk, often exceeding the concentration of even protein in the milk. But these molecules are not actually digestible by the infant. Rather, they serve as prebiotics for gut bacteria, helping to establish a healthy microbiome. They also have a variety of immunoprotective and immunomodulatory roles. And if you look at the right-hand side, the lower right image, one of these roles is actually acting as a decoy molecule. So pathogens, to infect an infant, they have to adhere to cell surface receptors on the epithelial cells, and then they can invade the cell. So what HMOs do is they act as this decoy molecule. So these pathogens come to and bind the HMO thinking it's a cell surface receptor. But the pathogen HMO complex is then passed through the stool, effectively preventing infection to the infant. And what's even more interesting is that the HMO concentrations are highest in colostrum, suggesting that colostrum will have the strongest protection against pathogens. And some in vitro studies have shown just that. If you look at that top row, there are culture experiments that these researchers did that showed what they basically did was they incubated E. coli with either standard growth medium on the left, raw colostrum, pasteurized colostrum, or raw mature milk. And each of the dots represent a colony of E. coli growing. And as you can see, raw colostrum prevented E. coli growth better than pasteurized colostrum or raw mature milk. And then these researchers also conducted experiments testing the adhesion ability of E. coli. So again, how well the E. coli could adhere to the epithelial cells. And if you look at the bottom left-hand corner, when they added E. coli to the, so basically what they did is they grew epithelial cells, added E. coli, and measured how much they adhered. And so in just standard growth medium in this white bar, you can see that there's quite a lot of adhesion. But when they added colostrum, there was less adhesion. And the more colostrum they added, the less the E. coli was able to adhere, showing a dose response effect. Then the researchers did the exact same set of experiments comparing raw colostrum with pasteurized colostrum and mature milk. And as you can see here, what the researchers found was that the ability to reduce E. coli adhesion was greatest in raw colostrum compared to standard growth medium or the other milks. Now, another reason that colostrum is important is because of its ability to reduce intestinal permeability and really permeability of any epithelial barrier, right? This happens in the mouth, the esophagus. But when we're talking about the intestine itself, we can think that basically the newborn has a very porous intestinal barrier, meaning that the spaces between each of these epithelial cells are actually quite large compared to adults. And this intestinal permeability is highest during the first week, making it easier for pathogens to cross the barrier and infect the infant. But clinical research that was done in preterm infants who have even leakier guts than term infants, what this research showed was that intestinal permeability was significantly decreased in infants receiving human milk versus formula in the first month after birth. And the infants who benefited most were those that received more than 75% of their diet as human milk, suggesting that human milk feeding helps reduce intestinal permeability in neonates in a dose response manner, meaning the more they get, the more they benefit. And results from in vitro studies suggest that this ability to reduce intestinal permeability comes, at least in part, from colostrum's ability to promote cell proliferation and migration. Now, cell proliferation and migration is a natural part of intestinal development. To help the intestine grow and repair damage, stem cells in the crypt of the villi produce epithelial cells that then migrate to the site of damage, wherever it needs to grow or repair. So in this experiment, researchers grew intestinal cells in vitro, and then they physically injured them by scraping the cells with sterile pipette tips. And they measured wound healing, which was a function of both cell proliferation and migration around the injured cells. So if you look at the left-hand side, in the control, this white bar, which only contained the regular cell growth medium, they found that 15% of injured cells healed. When they added a small volume of colostrum to the growth medium, they found that wound healing increased in a dose-dependent manner. And then they repeated this experiment and compared adding colostrum to the growth medium or pasteurized colostrum, raw mature milk, or raw pasteurized milk. So the raw mature milk is this darker bar. And what they found was that the colostrum, again, had the strongest effect on wound healing compared to either pasteurized colostrum or mature milk, whether it was raw or pasteurized. Now that we've talked about the importance of colostrum at the molecular level, let's zoom out a little bit and talk about volume. The volume of colostrum is low, and even though it may seem as though babies need more energy to replace the continuous nourishment from the umbilical cord, the infant's anatomy really was designed for this low volume. The body contains significant glycogen and fat stores that the infant uses as the primary source of energy in those first couple of days of life. And of course, we're talking about healthy term infants. There are definitely medical indications that do require intervention, but when we're thinking about that healthy term infant, we also see that the stomach volume is really, really, really small, 5 to 7 mils on that first day. And even by the end of the first week, the stomach volume is only 80 to 150 milliliters. And as you can see in this graph on the top, the amount of breast milk transferred to the infant is very low in those first few days, whether or not the baby was born vaginally or delivered by cesarean section. And human milk volume rapidly increases over this first week in coordination with that infant's stomach capacity. But what's even more interesting, in my opinion, is that the timing of feeds actually seems to be really important as well. In this recent study by Cato and colleagues, they measured milk volume at multiple intervals postpartum. And what they found was that peak production of colostrum occurs around 6 hours postpartum, followed by much lower production until lactogenesis 2 or secretory activation, as you can see over here, which is the start of copious milk production. And together, these data highlight the significance of receiving colostrum in those initial hours after birth, and it helps us to understand the physiological importance of early initiation of exclusive breastfeeding. So in summary, colostrum is unique in that its composition and volume adjust as the infant adapts to extrauterine life. Over the early weeks postpartum, milk volume is lowest in the colostrum phase, but this also corresponds to the highest concentration of maternally derived immune factors in milk. This is the same period that the infant mucosal surfaces are at their peak porousness, and the infant immune response to fight off infections is at its lowest. And it's plausible that giving formula or donor milk routinely early postpartum may actually disrupt this natural, coordinated, and complex transition to extrauterine life that colostrum serves. So now I'll hand over the presentation to Jenny, who will walk you through best practices for skin-to-skin and oral immune therapy, as well as share with you some resources to help implement or improve these practices in your units.
Okay, well, thank you, Sarah, for that wonderful review on the science of colostrum. I think it's really easy to see, and Sarah painted a great picture, that the immediate and lifelong impact, even a minute dose of colostrum, and when we compound that with multiple doses of colostrum, that could provide, that cannot be replicated by any other type of intervention. So we know that overwhelming evidence shows skin to skin is great for warmth, it's great for comfort, it really helps that baby to transition to extrauterine life. But how does that translate to breastfeeding success long term? Well, this Cochrane review provides strong evidence supporting skin to skin and its impact on breastfeeding. This particular review states that the rate of exclusive breastfeeding remains significantly higher among the skin-to-skin care group from 6 weeks to 6 months post-birth. And I think that's an important aspect for us to remember, because we know that we have strong initiation rates, but duration is lacking for breastfeeding. So the skin-to-skin really helps with the long-term breastfeeding success. So we know that change is difficult. Go ahead and advance that, Wendy. Change is difficult, but understanding the physiology behind improvements in standards of care really help us all to incorporate changes, no matter how difficult or different that may be. And this was a post on social media by an anonymous member, of course, who desires to drive change. And she says, looking to change the culture on my unit, the seasoned nurses think that all babies need to be supplemented with formula. They even agree with the patient when they say they have no milk and suggest formula right away. I'm a CLC, but I hate conflict. Help. So today in our webinar, I'm really excited to share insights with you on ways we can all change our thoughts on establishing lactation. So an infant's olfactory senses are heightened in the newborn period, and they play a large role in the infant's ability to use that sense to make its way to the breast to then initiate breastfeeding. So within those first few days, they're going to show a preference for the smell of their mother, especially her breast milk. So when that newborn is placed skin to skin with the mother, this heightened response stimulates those behaviors that we're looking for breastfeeding, and that's rooting and sucking. And as Sarah discussed, the opportunity immediately after birth to initiate these behaviors enhances that breastfeeding experience and provides a bolus dose of colostrum. And the theory behind that bolus dose of colostrum is that there's a lot of hormone changes that are taking place in the beginning, but there's also included in that, there's a lot of oxytocin. So we know oxytocin helps to contract those cells that allows that milk to come down. So we get that early on in the beginning. We know there's a lot of this oxytocin that helps to release a lot of that colostrum. So we know also that mothers need the support of hospitals. They need the support of us as healthcare workers to really engage them and trust that these physiological responses that are taking place in that early newborn period are in place. Now, again, I think as Sarah talked about, we're talking here about in that healthy term newborn. So the healthy term newborn, that bolus dose of colostrum that they get in the beginning is going to be enough. Okay. So standardizing the practice of immediate and uninterrupted skin-to-skin care after delivery is really key to that successful transition from intrauterine to extrauterine life and initiating that natural process of breastfeeding. So for the healthy term infant, that first dose of colostrum is enough. And this A1 practice brief, published in JOGN in 2021, discusses the importance and considerations of immediate and sustained skin-to-skin for that healthy term newborn, as well as that late preterm newborn. So it's important that skin-to-skin is taking place for at least that first hour after birth or until that first breastfeeding is complete. And that beyond that, we're extending and incorporating that into the postpartum period. We know that routine care practices, including weighing and measuring, should be delayed until that skin-to-skin session is complete. And I know this was really, really hard for me. We talk about our time management and nursing all of the time. And so making sure you get all of your measurements, your weighing, your APGARs, all of that done. I was very guilty of making sure all of that was done and then handing the baby back over to the mother. But I think, hopefully, especially after today, you're going to understand the importance that we cannot interrupt that routine, that practice of skin to skin that should happen immediately after delivery in order to facilitate and really give the best chances at initiating that successful first feeding in the beginning. And then researchers recommend that at least 1 to 2 hour sessions, as long as 5 hours per day for those first several weeks of life. This is additionally supported in the standards of perinatal care, and as we'll talk about in the next several slides, the American Academy of Pediatrics. So while we know skin-to-skin care is important, just as important are nursing and safety considerations. And I think I can speak for every NICU nurse that we're always worried about what may happen, right? And so we know I remember when we initially started implementing this practice in the facility that I was at, it was very hard. It was a hard change, a hard transition, because we need to be watching that baby at all times. But they recognize this in the practice brief, that a sudden life-threatening event can happen in a baby that otherwise appeared healthy. So to prevent any unexpected events, we are trying to teach the mother, the caregiver, the family, and the friends that are there all to be aware of the close monitoring. And ultimately, it comes down to the clinician that's there to do that monitoring. So A1 recommends that in the first 2 hours after birth, all newborns in skin-to-skin contact and or their breastfeeding should be continuously monitored by us as healthcare professionals. That APGARs, I think this is an important piece, APGARs should be completed while skin to skin. We can do those APGARs while those babies are skin to skin. I'm just as guilty as probably some others on the call about making them lay on the warmer, visualizing them for the first 10 minutes, but included in this A1 practice brief is that APGARs are completed while in skin to skin. Ongoing vital signs should be evaluated. We need all healthcare providers to be taught how to manage this skin to skin, including in the OR, another important aspect. Key here is that implementing appropriate nurse-patient ratios is important, and we know that that's important so you have the time as a bedside clinician to be able to incorporate this skin-to-skin care and also be monitoring that infant closely. And skin to skin, as we talked about several slides ago, should continue into the postpartum period and especially encouraged before all feedings, because remember, the baby is smelling, has that heightened olfactory senses, and that's going to stimulate that rooting and sucking and ultimately lead to more successful breastfeeding. So it's key to include the patient and the family in education. We want to make sure they understand the short and the long-term benefits of skin to skin. We want to make sure they understand positioning, the timing, that this should continue at least for the first hour until that first feeding is complete. And also include information on safety, the importance of avoiding distractions. I think the most common one we see is cell phone use. We know they're excited to take pictures, they're excited to post, but we really need all hands on deck, including the mom and as well as the healthcare providers. watching this baby, really paying attention to this baby as it transitions to extrauterine life, and then discussing the risk of sleeping when doing skin to skin. So the American Academy of Pediatrics shared in a clinical report guidance for skin to skin in the neonatal period. So there's a lot of words on this slide. I don't expect you to read them all, and I'm not going to read them to you, but I've included the reference as well as a QR code to the site that you'll have access to after the presentation. This is a really great resource and reference as you're evaluating, updating, or initiating protocols for skin to skin. Included in the same clinical report are suggestions for the safe implementation of skin to skin, and a few of those include developing standardized methods and procedures for immediate and continued skin to skin. Wendy, you can go ahead and advance. Thank you. Standardizing the sequence of events immediately after delivery, and that's really important for making sure that everyone is on the same page, training all the healthcare personnel and standardizing those methods of providing skin to skin, and then conducting frequent assessments as well. So we know that skin to skin contact is recognized as an evidence-based best practice, but the challenge is the implementation and variation in practice is inconsistent. So this guideline development process included a systematic review with a panel of experts, just like ourselves. Had many nurses, there were LCs, there were researchers, there were NEOs, there were obstetricians. And the result was a practical solution for implementing skin-to-skin contact after birth, which is going to help improve that chance of the successful first feeding, but then not only that, don't stop there, the long-term breastfeeding success. So the QR code here, which will also be available after this presentation, will take you to this tool. In November of 2022, the World Health Organization released new recommendations for the care of preterm and low birth weight infants based off of the practice guideline on the previous slide. So past recommendations included a kangaroo care after the newborn was clinically stable. Now the updated recommendation states that kangaroo care can be routine for all low birth weight and preterm infants and should be started as soon as possible after birth. So if you're like me as a clinician, you hear this and you think there's absolutely no way I'm going to put my preterm baby skin to skin immediately after birth with my mom, just because we're in the habit of that baby goes to the warmer, it's fully assessed. And definitely, if you have a baby that requires any type of respiratory support or mechanical ventilation, obviously that baby needs to be taken to the warmer and evaluated. But let's say, for instance, we have a 32-week preterm baby, maybe needed a little CPAP in the beginning, a little bit of respiratory support to kind of get them supported and going, but they transitioned very nicely. Probably we have a pulse ox on them. That would be the baby that we could take back to skin and allow them to continue that transition period on mom and skin to skin for a period of time. So just wanted to point out these new recommendations for the preterm and low birth weight infants as of about a year ago. So this is very near and dear to my heart, implementing oral immune therapy for preterm infants. We know we've talked about skin to skin in the newborn period and how that really equates to successful breastfeeding. When we talk about breastfeeding in the beginning, we talk about those babies getting the benefits of the colostrum. But given the physiological roles and clinical benefits of colostrum, there's really increasing interest in using colostrum as immune therapy for infants born prematurely. So just to begin with, I want to just briefly go over what is oral immune therapy. Well, it's the practice, one definition is, it's the practice of administering a small amount of colostrum to the oral mucosa for absorption through a syringe or swab. Research has shown that providing colostrum orally through a syringe actually increases urine SIGA and lactoferrin. Sarah was talking about the importance of those, and very important in a preterm infant. And this is really that increased urine SIGA and lactoferrin is indicative of effective absorption of those immunoprotective components that are so important in this patient population. So oral therapy allows an infant to have that same coating as a baby who's able to breastfeed. Otherwise, these vulnerable preterm infants would have that oral coating bypassed through a tube feeding or just because they're NPO status. So this allows that baby to have that oral coating even though they may not be at the breast. NAN's position statement on the use of human milk in the NICU states that oral care with human milk should be used to promote immunological defense as well as positive oral experiences for the infant. So when we talk about oral immune therapy, that's a little bit different than just maybe oral care where we're just trying to clean the mouth. This oral therapy is really providing immunoprotective properties through colostrum, and then once mom gets to mature milk, we can still continue that oral immune therapy. But it's important to allow the parents to provide this oral immune therapy if they're available. That psychological benefit and motivation to continue pumping can really be impacted by allowing the mother or the partner to be able to provide care to the infant in that way. So what resources and references can be used to implement such policies and protocols? That's what we hear a lot in the field. I cover about a third of the United States. So I'm in a lot of NICUs. I'm in one today out in windy, cold Chicago. There's a lot of different practices in place, and it's a lot of times what I hear is, where do we start? How do I even begin to implement a policy of this magnitude? So this is a collection of evidence from a systematic review published in October of this past year. Included in here are randomized controlled trials comparing oral application of colostrum or mother's own milk with a placebo. And most investigators, you can see the intervention, they applied 0.2 mLs of the placebo or of colostrum or mother's own milk to the buccal cavity. They did this with either a cotton swab or a syringe, about somewhere between 2 and 4 hours, and there was a variable duration between all of these. 48 hours to 30 days was most frequent, but I will tell you in some of these reviews, there was a real urgency to have LND, which I think is so critical, helping these moms pump initially and get the colostrum to the baby as quickly as they could. So some of these studies showed that as soon as they had drops of colostrum, those drops of colostrum were administered into the baby's mouth and some as early as within that first hour. So what this showed was that application of mother's own colostrum significantly reduced the incidence of sepsis in any stage of NAC. The colostrum group achieved full intraoral feeds 1.75 days sooner, and they had a higher weight at discharge. So this continues to be an active area of research that shows no risks, but many, many potential benefits. Now, another resource, working with leading experts, Medela has created simple but effective resources that NICUs can use to assess their human milk practices they have in place to really help collect data, to identify potentials for improvement and implement evidence-based best practices. So this is an example of a non-branded resource that can be used to implement oral therapy in your NICU. It defines oral therapy, it covers the importance of the why, and provides guidance on implementation and auditing. Additionally, this is a policy that's available on the Internet from Royal Prince Alfred Hospital. It's a guideline, and they actually call it immune supportive oral care. A very, very thorough policy. The reference will be available after this webinar, but this just helps act as, you know, a guideline or a blueprint for maybe implementation in your own NICU. And this was a poster presentation out of Children's Health in Dallas. I've worked closely with many of them, wonderful hospital, and they are really working to implement their oral immune therapy in their NICU. And this is a great resource with many supportive materials and supportive documents on here, and it kind of shows their outcomes as well. So again, I just added this here just as a resource for you. And lastly, important considerations that I think are important for implementing oral immune therapy, and some that we just don't even think about. Workflows are really important to consider. We have to think about what is the proximity of the NICU from L&D in the postpartum areas. So when we get those drops of colostrum, who's going to be responsible for delivering that freshly expressed colostrum to the NICU? Fresh is best. So is this something we can task the support person with so it's transported promptly? And it's also a way to have that support person involved in the care. A multidisciplinary approach is important. That helps improve the coordination of care for patients, helps bridge that connection between the different disciplines. We can all, when we all do a roundtable discussion, decision making to obtain best practices, coordination of those workflows, and it really empowers each team with the knowledge of the importance of oral immune therapy. And I think that's one important piece we don't need to take for granted. Sarah has gone deep into what is the benefit of colostrum and what can colostrum provide to these infants, and it's an evolving area of research. I think we can learn something new each day, but when we understand the why we're doing something and the importance of this oral immune therapy, it just propels those clinicians to really want to engage and make that change in practice. Education with the L&D team. I think L&D, many hospitals that I work with, we try to really encourage L&D those clinicians to really engage those moms, and either, obviously, if we can have a baby that goes straight to the breast, that's what we want. But if we have, in this instance, a NICU patient, we want those moms to start pumping and hand expressing early on so we can get that colostrum to the NICU infant as promptly as possible. So the L&D team should be able to briefly discuss with mom the importance of colostrum and its role in oral immune therapy, so that we can so that mom understands the importance of early pumping. Standardization is big. Protocol implementation for this very vulnerable patient population where feeding management varies so widely is an important step in eliminating that practice variation and ensuring all providers are on the same page. It's also important to consider the type of syringes as we are evolving into the infant world. Infant, if you're not aware, is a safety enteral feeding syringe. With the sheer design of that, they have rough edges. So keeping, if infant has been implemented into your NICU, or if it hasn't yet, think about this as you implement, that oral syringes for oral care are very important. So this may involve the safety committee at the hospital helping to justify the case for oral syringes and the safety behind them just for oral care. So for more information on this, you can reach out to your local enteral feeding supplier. It's also important that all providers, including NEOs, occupational therapists, bedside nurses, L&D, postpartum, just everyone understand why oral immune therapy. So for example, what I've heard before is it's important that an occupational therapist and a NICU nurse understand an infant doesn't need to be queuing to have OIT. So OIT is more about the coding and the providing those immune factors. It's not about the infant swallowing or being able to swallow. So that's an important piece here. Involving parents in the practice of oral immune therapy is also important. It really helps support the provision of colostrum when parents or significant others feel that they can be involved. So when a mother can provide what she has pumped and hand expressed, that really motivates her to continue pumping. So it may be important to discuss. I've heard hospitals say that we discuss plans with parents about visitation and when they're going to be available, so we know when we can ensure that that baby's getting freshly expressed colostrum. Charting. This is, if we think of it as a therapy, it's really important that we have a place to chart oral immune therapy. And so that's something that may have to be discussed with whoever owns your charting system, and it may have to be added. Okay. So I just want to touch, I think I would be remiss if I didn't touch on this. Intranasal human milk therapy is becoming more, we see it a lot more across the nation. Intranasal human milk as stem cell therapy in preterm infants with intraventricular hemorrhage is up and coming. And Dr. Rebecca Hoban, she's a neonatologist and researcher, was an instrumental part of the first prospective trial in the world to study the long and short-term outcomes of intranasal therapy. And they instilled 1.6 mLs, of course, in divided doses per day of fresh colostrum or mother's own milk in the noses of these preterm babies with IVH. And they found it to be tolerated well. Their thoughts were that these stem cells and bioactives could reduce brain injury based on animal models. So the outcomes are still awaiting publication, so more to come soon. But it's exciting to know that human milk may play yet another amazing role in the life of an infant, providing protection, nutrition, and healing. So in summary, Sarah and I really hope you've increased understanding in the science of colostrum, and based off of that you're energized to either implement, revise, or continue current practices in your hospital that support that early provision of colostrum to all infants, whether that's term, late preterm, or preterm. And we as healthcare providers, we have that unique opportunity to support not only the immediate health of these vulnerable infants, but the lifelong health by ensuring that each infant gets their mother's milk. We know mother's own milk is best, and that starts with colostrum. So a large body of evidence suggests that feeding human milk, even one time, confers the benefits to that recipient infant. So at this time, we're going to open it up to more of an interactive poll, and we want to learn a little bit about your practice. And so I'm going to, I think Wendy here, let's see here. Our first question is, do you practice skin to skin prior to routine newborn care? Meaning we allow for weights and measurements to be delayed in that healthy newborn population. I'm going to give you a couple of minutes to answer that, and then we'll see where we are across the board.
Okay, Jenny, we're at about 50%. We'll give it another second.
Okay, sounds good. Oh, wonderful. Okay, this is wonderful to see. Okay, so this is one change. You know, I think back 20 years ago, there was not that routine skin to skin, and so we've come a long way, but this is great to see. Okay, our second question is,
sorry about that.
Oh yeah, now this is challenging. Do you practice skin to skin in the OR? So yes, no, sometimes. Let's see what we have here.
Let's just give it another moment.
Okay. Okay. Yep. And that is challenging, practicing skin in the OR, and there's a variety of reasons that I hear that doesn't happen. I think maybe this will carry over into our next poll question, but okay. So what are your greatest challenges as a clinician initiating skin-to-skin contact immediately after birth? And if you'll just select one, probably a combination, but select your top one. Too many other tasks to complete, staffing issues, birth parent request, no policy or protocol in place, or just knowledge gap related to the importance of skin-to-skin.
We'll give it just another second.
Okay. Okay. Okay, so in education, I love this, HCP's knowledge gap related to importance of skin-to-skin. So I think many times what I see is it's not that clinicians don't want to put that practice into place. It's why do I need to put that practice into place? And so that's a passion of mine, is to help, and that's why we're on the call today, is to really help bridge that gap and give a better understanding of why we need to be placing these babies skin to skin, and what physiologically is that doing, and also what are the we know colostrum is great, but why is it great, and what all does it do? So too many other tasks to complete. Oof, as a bedside nurse, I understand that too. But I always say that if I went back and I was bedside in the NICU, I would never ever take look at feeding the same. And I think maybe many of you on the call, hopefully I'm not alone, but there are so many other things. I remember I used to think about respiratory all the time. Respiratory, that was so important. But thinking back to now, I'm solely focused on nutrition, being around breastfeeding. But really, it all begins with that, right? We need the immediate benefit of, obviously, we have to stabilize and get that respiratory system stabilized. But what we do from the very beginning and providing that colostrum in the very beginning really is going to be supportive for that lifelong health of that baby. So I think that's going to end it for now, and I think we can open it up. I don't think we have very much time to open it up for questions, but whatever we don't get to, we will try to respond to those.
And we did have one other thought-provoking question we wanted to mention. What are some challenges you have seen in practice implementing skin-to-skin care? Just something to think about. And if I may, I'll read I think the only question we're going to be able to ask today is, how often is OIT safe when baby is NPO?
Yep, it's a great question. So OIT, and I think it goes back to the randomized controlled trials, you'll see a baby in some of those randomized controlled trials that were in the review that I think we'll leave as a resource. The systematic review showed that it started within like an hour after birth, and then it was still every 2 to 4 hours for a baby that was NPO. So the idea is that we're just coating a layer. We're thinking about a layer, kind of going back to what Dr. Reyes had said, was we're thinking about that mucosal lining. So all we're trying to do is coat that oral cavity, not actually feed the baby. So I think there is probably every 2 to 4 hours is what we typically see.
Perfect. And I think those are the only questions we're going to be able to address. Dr. Reyes, do you have any final things you might want to say as we
Yeah,
wrap up?
thank you so much, Jenny, for really helping us bridge that gap between the science and the practice. I hope everyone today got a little bit of both, the importance, the physiological importance of provision of colostrum early, and also be able to take away with these resources actionable steps to help improve initiation of colostrum provision and early initiation of breastfeeding in your unit. So thank you so much for your time.
Perfect.
Thank
What
you.
a present.
Okay.
Oh, sorry. Sorry about that. What a presentation that was from both of you. Thank you, Dr. Reyes and Jenny, and thank you everyone for attending today's webinar, Colostrum Mastery, Bridging the Gap Between Science and Practice. Once you leave today's webinar, you'll receive a survey on the presentation, and we would appreciate if you would complete that and provide feedback. You will also receive a follow-up email with a link to the survey. Please provide feedback with that option. We are trialing a new process for the distribution of certificates after the webinar. If you've elected to receive continuing education credit for today's webinar, please allow up to 2 weeks for your certificate to be sent to you at the email address you provided. Please also note before we end, there are handouts in the handout section if you want to click on that to download. And last but not least, on behalf of Medela and our presenters, thank you so much for joining us today. We apologize for having gone over, and have a great rest of your afternoon. Just click